Next session will be Biliary6, Interventional EUS for biliary diseases. Moderators, please.
Good morning, ladies and gentlemen. I'm Dr. Ichiro Yasuda at the University of Taiwan. So this session focused on interventional EUS for biliary diseases. As you know, this technique is advancing rapidly. So we welcome five speakers. First speaker is Professor Isayama. Hello, Sandeep.
Morning.
Hello.
Okay. I will chair this session with Professor Isayama and Professor Sandeep Laktakir. I will introduce the first speaker. First speaker is Professor Isayama. As you know, he's a leader in this field, not only in Japan, all over the world. So he will talk about proposal of terminology and classification in interventional EUS. Okay, please.
Okay, thank you very much. Kind introduction to Professor Yasuda. And thank you, Sandeep, my friend. And I want to special thanks to the both Professor Omota and Shina to give me a very good chance to share our recent work. So please give me please show my slide. So I want to talk about proposal of the terminology and the classification of the interventional EUS. This is my COI slide. So this presentation about terminology of the interventional EUS. So recently, the publication of about interventional EUS year by year increasing, and but terminology not established, and there are many confusion, especially using the word. So then JGS decided to establish the terminology of the interventional EUS. This slide shows the subcommittee of the terminology of interventional EUS. I'm a chair of this committee, and Professor Yasuda and Dr. Nakai are there, also a member, and also Dr. Hara. And this time I talk about our proposal, and in my slide, the many slides are provided by Dr. Nakai. After our discussion, we decided to classify the interventional EUS into the 5 categories: EUS-guided sampling, through the needle examinations, EUS-DA. DA means the drainage/osmosis. And the trans-eschar procedures. I will explain ESCL later. And the other one is the ES-guided delivery. I will introduce one by one. Firstly, sampling. So very long time, we used the ESFNA as a general term of this procedure. But ESFNA is not suitable for the current our procedure. So then we employed ES sampling, but ESFNA, so remaining, I think. So then we described simultaneously sampling and ESFNA, but mainly sampling we mean. And look, not only the aspiration, but acquisition. So aspiration sometimes are not suitable, but acquisition may be suitable. So then we propose both ES sampling and the ESFNA. A means acquisition. Now this procedure classified by a target sample or a needle type. Target sample, USTA, tissue acquisition, and free sampling, and a needle type. Needle type. So basically, we use the FNA needle, so very simple cutting of the tip of the needle, but FNB needle, so many special configuration at the tip to get a histological core. So recently, the many doctors divide the FNA needle and the FNB needle, and also using the procedure name FNB or FNA. So then we according to these papers, so divided into the FNA and FNB. And this is a fluid sampling. So ESTA, so maybe you know, and sampling is also available. So this VTR shows the sampling of the ascites, but other situation, the cystic tumor in the pancreas is also available for the fluid sampling. The recent topic is ESTA for the CGP. Dr. Hala's team published 19 gauge needle is better than the 22 gauge needle for the Foundation 1 or CGP procedures. So it is very rare to detect druggable mutations. But I want to introduce our case. So this case is a recurrent case after the lip resection. Then this case basically received gemcitabine plus nab-paclitaxel and the subsequent FOLFIRINOX. But we switched to the pembrolizumab because of the we detect MSI positive, MSI high. So after the introduction of the pembrolizumab, the CA level dramatically down and body weight also dramatically increased. And this patient showed a complete remission after about 4 years. So it is very rare to get druggable mutation, but such kind of the case we experienced, we should perform the ESTA for the CGP. But the other aspect, so ESTA sometimes cause such kind of the very severe, serious adverse event after the rejection. So this is a nationwide survey. The needle tract seeding, so detected in 0.8%, mainly in a transgastric. So transduodenal ESTA, subsequent pancreaduodenectomy, no needle tract seeding, but ESTA from the gastric stomach, and after DP, so sometimes such kind of the complication occurred. We should think about this type of the complication. Okay, next topic is TTNE, through the needle examination. Recently, we can insert many miniature devices through the needle. So imaging and measurement and biopsy. So imaging, we can perform the many imaging modality and the measurement. So portal pressure gradient measurement recently increased in the world. So unfortunately, this is not available in Japan. So this slide shows the PPG measurement. So both punctured both portal vein and hepatic vein. And this is through the needle biopsy. So a miniature biopsy probe through the needle. It is also beneficial for the some situation. This slide shows the needle through the needle imaging. The user CLE miniature probe and miniature fiberglass. So puncture with a 90 gauge needle, the cyst, and the cystoscopy by your legacy spy probe, and the subsequent CLE probe. These we cannot see the directly in a cavity, cystic cavity, but using the this type of the procedure, we can see the intracystic component. It is also beneficial and maybe developing in the near future. EUSDA, drainage/anastomosis. So this category is including the three items. So first one is the drainage anastomosis of the organ. Second one is the drainage of the acquired fluid collection. Third one is anastomosis of the digestive tract. So the ESDA is a general term of these procedures. First one is the drainage of organs. Organ means a bile duct, gallbladder, pancreatic duct. So aim of the procedure, the ES-guided biliary drainage. But a procedure name is hepaticogastrostomy, anastomosis. So this further organ, so drainage method, but a simultaneous anastomosis. So then we use ESDA for this procedure. This is a US HGS puncture from the stomach. So we puncture the intrahepatic bile duct and contrast injection, guide wire insertion, and dilation of the puncture tract. Finally, we place a metal stent. So we can access to the bile duct after the placement of the metal stent or maturation of the puncture tract. So then this procedure is a drainage method, but a simultaneous anastomotic procedure. Now we are deploying partial covered metal stent, uncovered portion located in a bile duct, and liver parenchyma and in the intrastomach, so fully covered metal stent. So free covered metal to avoid the leakage of the bile juice or gastric some content. So it is recently the rapidly increase, especially in Japan, because this is covered by government insurance, and this equipment is also covered by insurance, and we can get reimbursement. Okay, this is a hepaticogastrostomy procedure. This is also a gallbladder drainage, ESGBD so-called. But a procedure name, so we should call the CCDS, cholecystoduodenostomy. So then maybe so many doctors only use ESGBD. But same as ESHGS, CDS, we should call the ESCCDS. Cholecystoduodenostomy or cholecystogastrostomy. So this case, the cholecystitis occurred after the placement of the biliary stent. We puncture the gallbladder from the duodenum with a 90-gauge needle and O2-5 guide wire insertion and dilation of the puncture tract, and finally place fully covered metal stent. And recently, we can perform the subsequent procedure. So through the metallic stent, we can remove the stones. Okay. So drainage of the acquired fluid collection. So peripancreatic fluid drainage, pseudocyst, ward of necrosis, leakage. So these target regions disappeared after the effective drainage. Then we don't use stomy anastomosis. It is only a drainage. So then we use transgastric ESPFD for pseudocyst. So the approach route included our terminology. This is okay. Skip one. The next one is anastomosis of the digestive tract. So we can make gastroenterostomy by ES-guided procedures. It is not a drainage procedure, but anastomosis. So then such kind of the procedures, so drainage, anastomosis, or only drainage, or only anastomosis. So general terms, we propose ESDA. And this is also a new word, TDAS. TDAS, transluminal drainage anastomosis stent. Traditionally, stent is placed at the stricture or at the papilla. But TDAS is keeping the root created by EUS procedure. So then we want to make a difference between a conventional stent and a stent in interventional EUS. So please memorize the name, the TDAS. Also ESCR, new word, ESCR, endosonographically created route. It is general term. The timing is after the puncture, established matured root, or cavity of the place of TDAS. Sometimes we perform the procedure through the axial stent or the metallic stent. So, and very important thing is that do not use the word fistula. Fistula is not inconvenient for sometimes for the inconvenient for the doctors or patient, but we created anastomosis. So then please use the anastomosis or tract, and the general term ESCR, ESCR. There are many trans-ESCR procedures. So most representative procedure is endoscopic necrosectomy via mature tract. So it is a new category. So we can perform the many procedures through the anastomosis. So then this slide shows some procedure of the trans-ESCR. So necrosectomy, stone management, and also this case, the insertion of the pancreatoscopy through the ESPGS. So this is a new category, trans-ESCR. So final one is the trans-guided delivery. Delivery means the application of the fluid, drugs, medications, or energy under ES guidance. So these procedures, including many procedures, techniques, and classify the technique and the conceptual goal. Technique, injection, fine needle injection, ablation, implantation. So conceptual goals are oncological intervention, neurological intervention, vascular interventions. There are so many procedures. This slide shows the ablation of the pancreatic cancer by a US needle. So this is also a US guided delivery. And this is also a US delivery procedure. This is an injection therapy for the pancreatic cancer published by our institution. So this is my final slide. So we, JGS subcommittee, propose a new classification of the terminology of the interventional EUS. Please memorize these 5 categories. Thank you very much for your kind attention.
Thank you for your very excellent keynote lecture. They try to unify the terminology and they propose some new terminology and classifications. I hope these new terminologies and classifications will be acceptable. Okay.
Please cite it.
Are there any questions from the audience? Or okay, Sandeep, do you have any comments?
This is a very novel talk by Isa. Some of the terms are a little difficult to grasp, but I think we'll have to read the paper to make it in our day-to-day practice. They're very natural to be followed. I think he makes the point very valid. And with only passage of time, we will probably memorize some of these terms and use it in a day-to-day practice. Thank you, Hiro, for sharing your thoughts and leading the group.
Thank you very much for accepting our proposal. Please use our new term in your paper. Thank you.
Okay, so Sandeep, is these classifications and terminology is acceptable for you?
I need to understand it. It takes little time. Hey, Isa is very quick.
Okay, now I'm preparing the paper.
Probably we can discuss later. Yeah.
Okay, thank you.
Okay, are there any questions from the audience? Okay, thank you, Professor.
Thank you very much.
Okay, we will move on to next topic, next paper. So next speaker is Okay, Professor Sumo Hijioka. Here we talk about diagnosis of cholangiocarcinoma with EUS. Okay, please.
Thank you, Chairman. Thank you for inviting me to the wonderful lecture. My topic is diagnosis of the cholangiocarcinoma with EUS. No COI. And endohepatology. Yes, in recent years, a new concept of the endohepatology has emerged, and various US-based procedures for the liver have been performed. Among them, US screening is the basis of the endohepatology, and many articles have described these techniques, mainly the convex US, from basic to advanced. Generally, the US liver observation, the left lobe is observed from within the stomach. And while the right lobe is observed from the duodenal valve with the scope in the longitudinal position. Therefore, US can observe almost all parts of the liver. So ICC is classified into the three categories: mass-forming type, the periductal infiltration type, and intraductal growth type. The purpose of EUS depends on the type of ICC. At first, the mass-forming type. Purpose of EUS for the mass-forming type is one is a detection of lesion, and two is a search for the intrahepatic metastasis, and three is a tissue collection. This table shows the diagnostic performance of EUS for liver lesions for many papers. This shows the diagnosis performance of EUS is high and is established to 75 to 100%. And also the meta-analysis shows the EUS diagnosis test had the accuracy of the 92% for focal liver lesion. And also, this is Aichi Cancer Center Hospital, Professor Hara's data. USFNA for liver lesion, not only the diagnosis, but also the CGP can perform by the USFNA. So I will show the mass-forming type, the ICC. This is located in the segment 4, around 2 centimeter. We performed the US procedure from the duodenal valve. This is following the left bioduct. We can see the left lobe and segment 4 around located here. So we can detect the S4 clearly. So we can perform the USFNB. So it can reveal the adenocarcinoma. So this is another case. This MF located in the root of the segment 6. At first, percutaneously ultrasound guided biopsy performed. It cannot be a diagnosis. CCC, ICC is sometimes very unclear because of even the mass-forming type. There is no clear margin, so it will be unclear. And from the transcutaneous, it is very far. From here to the hider. So we perform the USFNA. We can, using the duodenal valve to the longitudinal position, mass we can detect it and perform the USFNA. Thus, USFTA is useful for the right lobe of the liver. So next is introductory growth type. The cholangiocarcinoma's characteristic progress form of the viaduct carcinoma is two progress form. The one is a vertical direction infiltration to out of the wall. And the another one is a horizontal direction. So it means a superficial extension. Especially the intragrowth type, usually the papillary type. So it is easy to superficial extension. So at that time, we have to use a modality, not only EUS, but also the POCS. On the other hand, nodular type is not so frequently to superficial extension. So usually you use a CT and ERC. So this case is ICC with introductory growth type located in the segment 6 to 7, and dilation the viaduct is a B7. So ERC shows this defect, and the posterior wall, the viaduct cannot detect it. So we perform the POX and EUS to determine the extent of the progression. So this is the POX and left viaduct and right viaduct. We can see the mass in the right viaduct. So this is a B anterior we can detect, but we could not detect the posterior segment, posterior viaduct. However, there is no obvious extension to the hilar side. And also the EUS performed, this is a posterior mass and follows up to the CBD. We can clearly the CBD is no extension. And on the other hand, in the peripheral side, the mass extension to the posterior segment. So we determined that there is no extension to the hilar to left lobe. So this patient performs the right hepatic lobectomy, so which was curatively resectable. So the last one is the periductal infiltration type. This is the main purpose of EUS for PI type is, I think, the tissue collection. Because of the PI type is often difficult to diagnosis by the transpapillary biopsy. It's a reason that the epithelium is usually lost. So from the inside biopsy, it cannot be diagnosed as a carcinoma. So as this paper shows, the sensitivity of the ERCP is very low. So recently performed the ESTA for hilar stricture is slightly challenging. However, it can be safely performed when inside the plastic stent, and seeing the US, it can puncture the second wall lesion. It will be the mass and cancer exist in the submucosal area. So I will show the case 3. This is a hilar stricture, and the transpapillary biopsy cannot diagnose as a malignancy. So we performed the USFNA, seeing the plastic stent and wall thickening, and to confirm the vessel using the Doppler to avoid the vessel puncture, Melkman for the plastic stent, and USTA performed. So it can reveal the adenocarcinoma. So the PI type for the diagnosis is the US FNA is also very useful. So the summary, US is important for the diagnosis of the cholangiocarcinoma. It's desirable to perform the US diagnosis according to the purpose of each type. Thank you for attention.
Okay, thank you. Thank you for very informative lectures with beautiful videos. Okay, thank you. Are there any comments from the audience?
Can I have a question?
Okay.
Yeah. So thank you for the very excellent talk about tissue sampling by a ES guided procedure. So these region is except mass region, the thickening of the bioduct is not so big volume.
Yes.
So how about selection of the needle type? You use FNB needle or FNB or also gauge
Thank
size
you.
of the.
Thank you for your important question. At first, we will try the 22 gauges FNB is our first step for diagnosis. So if the puncture is very hard, sometimes we experience. So we change the FNB to FNA or the 22 gauges to 25 gauges. On the other hand, if we would like to want to the CGP, so at first we will try the 19 gauge at first.
So other concern is also perforation of the viral leakage.
Yes.
So for the cholangiocarcinoma, is there any adverse event like that leakage or something?
Thank you so much. We experienced around 60 to 70 cases for the HIRA stricture for the USFNA. So only one case, the peritonitis occur. Maybe the viral leakage.
Probably before ESFNA, you usually use a plastic stent.
Yes, thank you so
It
much.
may prevent the viral leakage.
Yes, yeah. I think it is also very important to avoid adverse event.
Okay, please, Dr. Matsubara.
Hi, I'm Saburo Matsubara from Saitama Medical University. Thank you for your nice presentation. I would like to ask one question. In the stricture type for carcinoma, there are two methods for obtaining tissue, cholangioscopy guided biopsy or EST.
Yes.
And many endoscopies prefer box guided target biopsy because it's very easy.
Yes.
And ES guided TA is difficult for, especially in the higher region. Which do you recommend when when you see the indeterminate biliary stricture at higher region?
Thank you so much. That's a very important question. As for the introductory growth type, we also use under box biopsy. However, the HIRA stricture is a PI type. So it is very difficult to perform even the POCS guided biopsy. But firstly, we will try the transpapillary biopsy. If the failure, so the salvage USTA performed.
Thank you. I agree with you.
Thank you.
Okay, transpapillary, conventional transpapillary biopsy is fast.
Fast. Yes.
If it was failed,
Yes.
you try to perform box guided.
Yes.
Okay.
Yes. Or yes. Simultaneously we perform the box when the introductory growth type.
Okay, thank you. Are there any questions?
May I?
Okay, Sandeep, please.
Thank you, Dr. Susumu, for a wonderful presentation.
Thank you.
Are you concerned about doing an FNA through the duodenum for a needle track metastasis? That's one. And second, with the presence of stent inside, sometimes the stricture may not be very well visualized. Would you consider doing an EUS FNA of the bile duct wall before placing a ERCP stent?
And I'm sorry, I cannot hear the first question, but the second question.
Metastasis.
Metastasis. I'm sorry. Thank you so much. Yes. We performed also the metastasis from the gastric cancer or the pancreatic cancer. And the second question, yes, it is very important to avoid the adverse event. It is better to insert the plastic stent. After that, we will try the USTA for the wall thickened wall. It is very helpful to the milkman to the biopsy. Thank you.
Okay. Okay, thank you, Professor
Thank
Hideo.
you.
Thank you.
Okay, move to the next paper. So next paper by Professor Kazuo Hara about current status of USBD. Kazuo Hara from the Aichi Cancer Center. Please start your lecture.
Yes, thank you very much. Thank you, Chairman. Thank you for organizing committee. Thank you, President Dr. Sina and Dr. Omata. My presentation is the current status of USBD. This is my COI. This is my team. Thank you for my colleagues. So this paper, very recently, this paper was published. Adverse event with USBD, they mentioned. So, can you see? So overall, clinical success rate is more than 95%. Adverse event is nearly 13%. And major adverse event is very low, less than 1%. Reintervention rate is 16%. So this is very similar with the ERCP result. Very similar. Okay, can you understand? So this picture, the recent advance, recent device, and recent equipment, instrument. So do you know, this is a Fuji new scope. This is a brand new, this is very good scope for me because we can puncture B2 very easily. And this is spring stopper by Dr. Isayama. This is a very nice stent to prevent internal migration. This is a Tornus dilator. This dilator is invented by me, but very good dilator. So like this situation, USBD now became easy and simple. This is the video. This is a Fuji scope. We can use a lock system. This lock system is very strong. Can you see? This is 018 wire, very slim wire, but non-dislocation. Very safe. I love this scope. And the puncture angle is different. Fuji scope is perpendicularly. This is a conventional scope. Can you see the difference? So Fuji scope, we can puncture B2 easily and safe because very strong, very strong, sorry. We can lock very strongly the wire. This picture is the appearance of the scope. Forward viewing scope, green one is a Fuji scope. This is a conventional scope. Maybe you can understand the difference, the angle of the scope. Quite different. And we recommend the B2 puncture also using forward viewing scope. Forward viewing scope and the Fuji new scope is very similar function. We can puncture B2 by forward viewing scope and Fuji scope, both okay. This is a schema, forward viewing scope, Fuji scope, and conventional scope. So after B2 puncture, procedure make easier, much easier, because wire direction is very strong. No up and down, no branch usually. So very easy. So after B2 puncture, just dilation put stent. But after B3 puncture, wire negotiation, sometimes wire into the peripheral or something. Dilation is also very difficult. But after B2 puncture, very easy. And this picture is a forward viewing scope versus Fuji new scope. Very similar, but the forward viewing scope has a little bit advanced. We can puncture, this is the same patient. This is a forward viewing scope, this is the Fuji scope. So if you use a Fuji scope, puncture site is esophagus. But forward viewing scope, puncture site is in the stomach. Like this, we can perform B2HGS. So my opinion, ESBD became now a simple and safe procedure now. Maybe in high volume center, maybe. So now indication are changing or not? Of course, should be changed. But more than 10 years ago, I recommend primary ESBD for inoperable distal obstruction, more than 10 years ago. Still now I recommend primary ESBD. So recent our procedure, I want to show you. Recently, we use a Francine needle to make a big hole for CDS and non-dilation and put stent. This is our result. Of course, high technical success rate, 100%, very low adverse event. This is a video. This is CBD. I use Acquire 90G needle. So we puncture CBD. This case, I performed the CDS, punctures using 90G Acquire needle. Aspiration first, of course, and then inject small amount of contrast. Next, guide wire. And then non-dilation method. Can you see it? Next is a Hanaro benefit, very slim stent, 5.9 French. Easily, no need dilation, completely no need dilation. And open stent in the bile duct, nearly 2 cm, and pull back the stent, pull back a little bit, and fixed, and then open in the channel, and push out the stent into the anal side. Anal side is very important. Okay. This is a forward viewing scope. So we need just 5 or 10 minutes. Very simple. So this paper, the Professor Isayama reported. So 6 years ago, Japanese guideline. What are the indications of ESBD 6 years ago? Of course, patient failed or difficult ERC. But recently, European guideline, 2 years ago, what is the indication of ESBD? Of course, rescue, but they commented, primary ESBD for inoperable distal biliary obstruction by expert. This situation is acceptable. So European guideline accept the primary ESBD for inoperable only by expert. So this is very brand new. But, however, this paper reported, before operation, ESBD is good or not compared to ERCP. This is a retrospective and comparative study, but they mentioned ESBD is better because higher rate of surgical clinical success and shorter hospital stay. Of course, retrospective, maybe not so correct, but in our center, already before operation, pancreatic cancer only, but our indication is B2HGS. Our data, hospital stay is the same. Surgical clinical success rate is the same, but bile duct culture is different. So HGS bile duct culture is almost negative. And transpapillary bile duct culture is sometimes positive. This is quite different. And for surgeon, no stent in the CBD, this is very good for surgeon. Maybe easy to operate because no stent, no adhesion by stent. HGS is very far from surgical area, so maybe HGS is good for surgeon technically. And what is the contraindication is BD? 6 years ago, Professor Isayama, including me, including Professor Ichiro Yasuda, they mentioned, of course, vessel and organ and bleeding tendency and much ascites, of course, 6 years ago. But recently, 2 years ago, European guideline, of course, same, but they commented, procedural drainage of ascites may be helpful, may be safe for ESBD. We reported already much ascites patient, 10 cases, our reported 10 cases, much ascites patient, we put percutaneous drainage before ESBD, and then we perform the ESBD. After 2 or 3 days later, we remove the percutaneous drainage. In this situation, safety, very safe, not very, I don't, because just 10 cases, but all cases are safe. No infectious peritonitis, no infectious or something. Another paper, this paper performed ESBD with ascites patient, but non-pre-procedural drainage. They mentioned good technical success or good result, but I think clinical success is nearly 64 ascites patient, not so good. And one case is, mortality is one case, nearly 10%. So this report is, I think, not so good result. So I recommend strongly, before procedure, ascites drainage is necessary. So final paper, this is a review paper from Dr. Ban, Dr. Loeb, and Dr. Shyam. This is a very famous endosonographer. They reported, they mentioned, in near future, their proposal, if tissue diagnosis is required, single session FNA and ESBD is recommended. But tissue diagnosis not required, ERCP first. This is their proposal. My proposal, almost all malignant cases, without operable BTC and multiple obstruction. This is an indication for primary ESBD. This is my opinion. So my message. Now, prime time to consider primary ESBD for you. Thank you so much.
Thank you very much. Excellent talk about very exciting topics. And so according to the improvement of the devices and the procedures, indication will be changed. And your opinion is the primary BD is so currently available. Okay. Upon discussion, there are any question from the audience? So Sandeep,
Yes.
can you accept primary ESBD in your institution?
Kazuo is very talented. Thank you, Kazuo, for a wonderful presentation.
Thank you, Sandeep.
It's a, but still, I think we are still old timers prefer ERCP first.
Really?
And
Really?
then go yes.
You can perform.
But we are changing our ERCP people that we can do it directly. I think we need more trials with larger numbers, head-to-head trials, and multi-center. Then only we can say whatever trials which have come compared to ERCP with USBD for distal malignant biliary obstructions are very small numbers, 30, 60 maximum. I think we need larger numbers. And maybe the hot Axios type stent is also good for colodocoduodenostomy, which will make the procedure safer and quicker.
Okay, thank you very much. Other opinion from the audience? How do you think about it?
Okay, okay, please.
Oh, Rajesh, please.
Hi, Hero. Hi, Sandeep. Good to see you on the screen. So, actually, just taking it forward, Sandeep has already explained that in our unit, we first prefer ERCP over EUS for primary biliary decompression of the bile duct strictures because it is a long established procedure. So we cannot just discard it. Yes, we are there. We can do it in future. Maybe if we have more data, we are more proficient in because the number of people who are performing ERCP is much larger than people who are proficient in US procedures. Okay. Thank you.
Okay, thank you very much.
Okay, I have a short question. Okay, I want to ask you about type of stents. Which type of stent do you usually use for US HGS?
HGS is fully covered. Fully covered, 6
metallic,
millimeter.
metallic
Yeah.
stent. Always,
stent, yes.
always metallic.
Always.
Okay.
Yes.
Okay, so I totally agree with Dr. Hara in the near future. But currently, thinking about not expert doctors, it is too early thing, I think. But in the near future, maybe it is getting there, I think. Thank you very much,
Thank you very
Dr. Hara.
much.
Okay, move to the next topic. Next topic is the ESGBD. So we invited Jae Cho from Korea. So he's now in Yonsei University, Gundam Severance. He's also rising star in the world. Thank you very much for come to our session. Jae, please.
Thank you for introduction me, and it's my great honor to present my topic, current status of USGBD. No COI. I covered their contents, history and technical procedure sequence, and real-world change and unanswered question. As you know, the cholestasis is a common gallstone disease with high incidence rate, and laparoscopic cholecystectomy is the gold standard for treatment for the acute cholestasis. Depends on the diagnosis criteria, including clinical, imaging, and laboratory findings. As you know, US guided GB drainage makes a paradigm shift away from surgical approach to minimal endoscopic approach. It is a promising, less invasive, yet effective alternative for patients, especially those at high surgical risk. Journey's ESGBD begins with the 2007. Two groups reported safety and feasibility of the ESGBD. One thing is from the Todd Baron from US group, and one thing is the Sang-Suri from Korean groups. After that, EMBD and the double pigtail prostant was introduced for the USGBD. After tubular SAMs and LAMPs were introduced, nowadays the USGBD is actively performed worldwide. Stand for the safe and effective USGBD, we have to see strict indications, and there is a backup, including surgeon and radiologist is required. In addition, special equipment is needed for the safe procedure, and most of all, operator must have a sufficient intervention EUS competency. Nowadays, the indication for USGBD are as follows. First, for GB drainage in high surgical patients with acute cholestasis. Second, removal of PTGBD in patients who are not candidates for cholecystectomy by allowing internal drain. And third and first, for the drainage of malignant biliary obstruction in select patients with failed ELSP and US-guided biliary drain. I covered the technical and procedure sequence. Initial step is the function and guide wire insertion. And most important thing is whether the patient really needs this procedure. This procedure have resulted in severe morbidity and mortality, so that for the successful USGBD, US view maintains a stable position during this procedure, and procedure should be carried out by predicting next step in advance. Leg of GB is a target. It is a safe and ideal point by GB immobilization, and puncture without blood vessel on the color Doppler, and stylet unmounted 90 gauge FNA needle was used, and aspirated small amount of bile juice and fluid for further culture and fluid analysis, and inject a contrast into GB, and 0.25-inch guide wire, especially angular type, is preferred, and guide wire coiling and looping sufficiently for stable positioning. Second step is track dilation. It is a mechanical and electrical cautery dilation can be used separately or in combination. As you know, this step is the most challenging step, so we needed cautions. First, it make an alignment angle between fixing pulse and needle axis, and predicting the level of wall resistance, and minimize dilation diameter for preventing bile leakage. In terms of the graded dilation, we used the hurricane balloon or land balloon. Hurricane balloon is a very steep shaft, so it very good pushability. However, land balloon catheter has a more pointed tip. It is useful for severe stenosis or a narrow hole, but it has limitation, use only 0.25-inch guide wire. In terms of cautery dilation, it is safe and trouble-free dilation method because the iatrogenic hole is created through the thermal ablation. There is a risk of bile leak and perforation. So I think that if you use the cautery dilation, USGBD must be completed. Third step is the GB stenting. There are many types of different shape, modified tubular SAMs or LAMs. There is a high probability of the stent migration and the dislocation, and stent placement should be carefully carried out while checking both fluoroscopy and endoscopic view. And because LAMS has a tendency of proximal migration, you should use the intrascope releasing technique for the stent deployment. Let me show you one case of the USGBD using tubular SAMs video clip. GB neck portion was punctured with FNA needle. After guide wire coiling and looping sufficiently, after that, a cystostom was used for tract dilation along the guide wire. It is safe and you can see the puncture. After that, because in this patient we approached the transduodenal approach, we used the stent placement after without tract dilation. You can see the stent deployment process. You can see on the US image, tubular SAMs was placed correctly. After that, successful USGBD was performed. Nowadays, one-step device such as hard axles and hard spaces with thermal cautery tip was developed. It can allow the stent placement solely on the US guidance without need for tract dilation, fluoroscopy, or guide wire placement. You can see the LAMS insertion is a very simple and under US image. Let's summarize the stent type, advantage and disadvantage according to the stent type. In plastic stent, it is cheap and easy for stent revision as a potential candidate of a sequential cholecystectomy, but it has a limitation of a smaller diameter, no tamponade effect. In the tubular SAMs, it has a longer stent patency and easy withdrawal recapture possibility and tamponade effect by SAMs expansion to prevent bile leakage, but it is expensive and risk of stent migration. In terms of LAMS, it has the longest patency and it has opposing effects to prevent the bile leakage, but it's too expensive and it has typical LAMS-related buried LAMS syndrome. In terms of adverse events, overall incidence is 8 to 18%, such as perforation, bleeding, bile leak, and recurrent cholecystitis may develop less than 8%. In the case, the PTGBD or surgery is main treatment tools. Nowadays, according to various guidelines, in experienced US centers, USGBD can be used as a definitive treatment at high surgical risk patients. However, there are unanswered questions and challenges in real-world application. I'll continue my talk with question and answer. First, which procedure would you choose during your holiday weekend? I'll show you one case. 75 years old male, gangrenous cholecystitis, jaundice, cholangitis. They have multiple comorbidities. Actually, he had jaundice. We performed the ETGBD and successfully performed. After 1 month, he had recurrent cholecystitis and cholangitis. So we decided to call the interventional radiologist to the PTGBD. After his condition is recovered, he underwent a subsequent cholecystectomy for that minute treatment. So 3 modalities of the GBD have their respective advantage and disadvantage. In center with expertise in endoscopic GBD, US GBD and ETGBD are preferred over PTGBD with improved outcomes. However, in most clinical institute and situation, PTGBD is easily and safely used. In this AGA clinical practice update, if GB perforation suspected on the imaging and they recommend PTGBD. If no perforation, ETGBD or USGBD were performed initially. ETGBD is preferred on the uncontrolled arthritis, potential future surgical candidate, and USGBD was made by the after multidisciplinary team approach. Second question is definition of high surgical risk. Actually, Orlando group showed that their retrospective case series, 3 of 25 patients who underwent USGBD is recovered, so that the presence of LAMS precluded a minimally invasive surgical cholecystectomy and necessitated conversion to open or subtotal cholecystectomy. So because a high surgical risk can be reversed, early implementation of USGBD, which may interfere with subsequent surgery, may be problematic. For patients who can recover, surgical risk should be reassessed at 4 to 6 weeks, so ETGBD or PTGBD should be considered as initial treatment. Considering this clinical experience, USGBD should be only applying never surgery candidates, I think. Never surgery candidates including inoperable malignancy, advanced cirrhosis, primary pulmonary hypertension, irreversible severe neurological dysfunction. Third question is long-term GB drain required. ESE suggests that transdural USGBD is preferred. However, in many cases, the transgastric approach is used. However, it is an advantage for subsequent cholecystectomy. It has the higher risk of food infection. So a new strategy has been attempted to replace LAMS, SAMS with double pigtail plastic stent when long-term drain is required after USGBD. In this case, 3 months after USGBD, actually he had a duodenal stent, a biliary stent. You can see the lots of the food material in the USGBD stent. So we decided to do fully covered stent removal and double pigtail plastic stent exchange. In the PPS exchange, the maturation period of transluminal fistula tract is a very important issue. So first question is, when is the maturation of fistula tract in USGBD? We performed the in vivo animal study, a surgically bile duct ligation. This study aimed to assess the maturation time for fistula tract formed by USGBD using LAMS. You can see the GBD distension, and the LAMS was inserted by the USGBD transgastric approach. After LAMS endoscopic removal at 7 days after USGBD, you can see the maturation track, and there is no contrast leakage during the procedure, and microscopic and gross specimen shows that fibrosis and mature fistula tract. And at the 14th day, about 2 weeks after LAMS removal, more matured tract was found, and there was no contrast leakage, and fibrosis was noted. Interestingly, we have 2 cases of proximal phalange misdisplacement during LAMS insertion. In that case, because we have the guide wire, stent in stent using LAMS or longer follicular SAMS was possible. In these 2 mini pigs, and they remained alive until the end of the study. So let's summarize my talk. In transgastric USGBD, a fistula tract is formed even just 1 week. So LAMS can be removed and exchanged 1 week. And endoscopic rescue therapy is highly effective for proximal phalangeal displacement of LAMS. As you know, USGBD is very challenging. So the surgery is considered later. PTGBD or ETGBD is preferred initial treatment. However, in never surgery phase, USGBD is another option. Before the LAMS was placed in by the USGBD, new treatments such as gallstone removal, resection of GB polyp, and transluminal endoscopy is possible another new treatments. So let's summarize my talk. Endoscopy play a crucial role in the evolving treatment of ocular cholecystitis, notably with the advent of the USGBD or ETGBD. We need a clear indication of USGBD, and USGBD presents a viable, safe, and minimally invasive alternative to PTGBD or surgical cholecystectomy in never surgery patient. However, we need the additional research. Thank you for your attention.
Thank you, Jahi. The excellent talk about summary of the current situation of the ESGBD. So, is there any question or comment from the audience? So, from your presentation, the possible indication of the ESGBD is non-surgical, unfit for the surgical patient. But so randomized clinical trial from the Korea, Sansuri, his trial is a resectable patient. How do you think about the indication about preoperative cases?
Actually, we did more study to establish the absolute indication for USGBD. So, but the Sangsuri study is now under investigation of the seeking the indication for USGBD, I think. So that actually we have many alternatives for the GB drain methods. So the USGBD is another good option, but it has a very complex and high risk of complications, severe complication, relative compared to US bile duct drain. So I think that we narrowed the spectrum of indication of ESGBD for the patients, so that I suggested that for never surgery patients is a useful indication for the ESGBD.
Great, thank you. Sandeep, do you have a question or comment?
I have a comment for Dr. Cho. That was a very nice presentation. Thank you very much. I think the message is very clear that patients who are likely to be operable in future, it is better to avoid EUS-GBD and prefer other methods. I think that's a debatable area. There are pros and cons on either side, but your message is quite clear and loud. Thank you.
Thank you.
Okay, thank you. As a question or comment? So in Korea, Jahi, which stent is most used for the ESGBD? You have a menu stent.
We actually used the tubular SAMs.
Tubular SAMs.
But Professor Moon developed the spaces, hot spaces, and Axios was introduced nowadays, so that we have to change the paradigm. So because the USGBD has really many bileaks, so we skipped the one step using the hot Axios or hot space system is more beneficial. So I think so. Nowadays we move to the lamps.
Okay. So maybe using the lamps, trans-esca procedure, so lamps, the stone removal. So actually, do you perform such kind of the procedure or only your stent placement?
Actually, after the stone removal through the lamps, actually I think at the later USGB stone as gold stone may be redeveloped. So that I'm not doing the stone removal through the lamps. Okay. Yeah.
Okay, thank you. Any question? Okay, Matsubara, please.
Thank you for your good lecture. I have one question. When you use the lamps for ESGBD, do you place a guide wire for the prepared to the proximal flange implantation?
Actually, we use the lamps only on the US guidance without guide wire. And after guide wire insertion is some kind of a positioning change. So it is difficult to GB puncture. But I think that safety is a major issue. So in case of the stent deployment error, in that case, the guide wire may help to the rescue endoscopy treatment. So I usually prefer the guide wire insertion during the procedure. But some other groups, they don't need the guide wire, and they usually one puncture. Yeah.
Thank you.
It's okay, enough discussion. Okay, Jahi, thank you very much for excellent talk. So I want to introduce the final speaker of this session, Professor Saburo Matsubara, and to talk about barrier access in intervention. Yes, he's now the associate professor in Saitama Medical University. Saburo, please.
Thank you, Chairman. It's a great honor to be here. I will talk about biliary access in interventional EUS. No CEO word. Biliary access is the first step in the endoscopic treatment for biliary diseases. Transpapillary access via ERCP is the gold standard, but sometimes impossible due to failed biliary cannulation, duodenal tumor invasion, or surgical altered anatomy. ESBD is a favorable alternative in such cases. In ESBD candidate, cases with inaccessible papilla can be treated with ES-guided anastomosis or antistatin. In cases with accessible papilla, ES-guided rendezvous, which is a method for biliary access, is also an option. Indications for ES rendezvous: in unresectable malignant biliary destruction, obstruction, anastomosis and antistatin would be preferred over rendezvous because of the simplicity of the procedure. However, for the treatment of benign disease such as BB, benign biliary stricture or bile duct stricture, bile duct stone, transpapillary approach combined with ES rendezvous should be prioritized because of easier application of various devices and multiple stents. ES rendezvous is also preferable for thoroughly examination of suspected cholangiocarcinoma as it follows the use of various devices and minimizes the bile leakage. You can see the standard techniques. First, selector approach route. Next, puncture and contrast injection and manipulate the guide wire in the duodenum. Then remove the US scope and insert the ERCP scope and grasp the guide wire and pull the guide wire out of the channel, and finally insert the cannula over the guide wire. In these steps, guide wire manipulation through the needle and bile duct to pass through the ampulla and stricture is the most difficult step and is the key to the successful rendezvous. There are three major approach routes, including distal extrahepatic bile duct from D2 route. Its scope position is short and scope stability is poor because unstable scope. But guide wire manipulation is very good. Next, proximal HBD from D1 route. This is a long scope portion and needle handling and guide manipulation is not so good. Last is left intrahepatic bile duct from stomach route. Short scope portion and scope stability is not so good. Needle handling or guide manipulation is not so good because the distance is very long. In addition, the right intrahepatic bile duct from D1 route is acceptable. And Dr. Kitamura reported the distal extrahepatic bile duct puncture from the stomach. Our candidate for approach route selection in CBD stone cases, for better guide wire manipulation, direction of the needle ampulla is better than Highland. Distance between the puncture site and the ampulla short is better than long. Then distal EHBD from D2 route is the best approach. This is a video in CBD stone cases. The bile duct is punctured and guide wire manipulated into the duodenum easily, and the US scope is removed, leaving the guide wire inside, and then the ERCP scope inserted, and the guide wire is grasped by snare, and cannula was inserted over the guide wire. It's very easy. In stricture cases, position of the puncture site to the stricture site is a major concern. Distal site is better than proximal site because no need to pass through the stricture. Then the distal EHBD by D2 route should be considered first. However, for the needle puncture, diameter of the bile duct distal to the stricture is extremely thin, and deformation of the GI tract due to the tumor invasion destabilizes the scope position. Tumor may be located on the puncture line. So if the first choice is unavailable, another approach route should be selected based on the stricture site, biliary diameter, and tumor location. In stricture distal CBD, the first choice is this one, but scope is very unstable. The next, I recommend this route, proximal HBD route, because the short distance from the puncture site to the ampulla. Last one is intrahepatic route. But the guideline manipulation in the D1 long position is difficult because the needle is directed to the hilum. So the scope maneuver to change the needle direction is very important. This is a video in proximal HBD from D1 route. This is a chronic pancreatitis patient, and we attempt first the distal from short scope position, but the scope was very unstable, and we performed the proximal route with long scope position. And guide wire inserted and pushed the scope and angle. The guide wire was directed to the ampulla. But there are differences in scope maneuverability in each product. Fuji scope, especially 740, is a big capacity than Olympus 1. You can see the each scope maneuverability. There are inserted 19 gauge needle and using up angle and elevator full. 740 is a very good maneuverability. Stricture at the middle CBD, the first choice is distal CBD because no need to pass through the stricture, but the diameter is very thin, so the difference, so the puncture is very difficult. Next, I recommend this route because the short distance to the ampulla. And finally, the gastric route. In gastric route, B2 is better than B3 because B2 puncture has better guide wire trajectory, but has a risk of transesophageal puncture through the diaphragm. To avoid puncture transesophageal, the scope maneuverability is very important. Good scope maneuverability allows the puncture beyond the diaphragm using 740. And caster support for difficult stricture is very important for guide wire pushability and stability. This is the pancreatic cancer cases using stomach route. The distance is so long, and the negotiation of the guide wire is very difficult. And I use a catheter to negotiate the guide wire, but it takes a long time. After the insertion of the guide wire into the duodenum, the scope was removed, and the ERCP scope was inserted, and cannulation was done. Stricture at the proximal site, you can perform first CBD route because no need for the passing stricture, but it's very difficult for thin CBD. In this case, gastric route is needed. In the stricture at left HBD, you should be first attempt in the CBD loop, and if failed, right interpreted bile duct from D1 route is available. This is the case with left lobe ICC. B6 was punctured and guide wire inserted and passing through the ampulla. And the scope was removed and the RCP scope was inserted and cannulation was performed using a hitch and ride technique. I propose the algorithm for ES rendezvous. Anyway, use the approach route in this order. Short scope position from D2, and long scope position with D1, and stomach route, and last, right interrupted by the route. Use the approach route in this order if the puncture is possible, regardless of disease type. Outcome according to the algorithm in our institution, D2 route, short scope position is the most used approach. A D1 route was failed in one case, but finally success was in all cases. Final biliary cannulation was successful in all cases, and time from the puncture to guide wire placement is lowest in the D2 scope position route than the other three routes. And I will talk about the cannulation method. There are three methods over the guide wire and along the guide wire and hitch and ride. Hitch and ride is a slit of the catheter was adjusted to the guide wire and simply insert the catheter. Dr. Nakai reported this technique and over the wire and along the guide wire and hitch and ride. Conversion to the other method was none in the hitch and ride. And time needed the insertion was very short. Dr. Iwashita reported the hybrid method with over-the-guide technique to manipulate the guide wire. The 16 dilator inserted into the ampulla and the over-the-guide wire technique was performed. Dr. Natsume recently reported 3 French diameter to hybrid method. It's very thin and very safety to reduce the bile leakage. In systematic review and meta-analysis, product technical success was 88% and product adverse events rate 10%. In summary, ES rendezvous is a useful method for failed biliary cannulation, especially for benign disorders or resectable cholangiocarcinoma. For a successful ES rendezvous, we need to familiar with various approaches, cannulation methods, and devices. Thank you for your kind attention.
Thank you very much for the talk about the detail of the ES-assisted rendezvous technique. Is there any question and comment from the audience? So, Sandeep?
And I think this was very nicely explained, and several methods here is guide wire manipulation is the key to success of biliary drainage.
Yeah, I agree.
What Dr. Saburo was mentioning, all the tricks of the trade we have seen from the experts, masters like you on the stage and in the audience. I think we have to keep trying ourselves with whichever is available at that time. Thank you.
Thank you.
Sometimes we are so switching to the ESBD, so during the ES-assisted rendezvous technique. Maybe I think the ESBDs are easier than the rendezvous technique. So how do you think about this comparing?
Yes, thank you for your question. I also think the ESBD, ES-guided anastomosis, is easier than rendezvous. Yes, rendezvous is a complicated technique with ERCP scope. But I prefer ES rendezvous in benign diseases because application of various devices, including spice coop and IDUS, and can be applied or multiple plastic stent. So benign disease or benign stricture and suspected cholangiocarcinoma is a good candidate for its rendezvous.
Okay. For the benign diseases, you select so yes, assist rendezvous first. For the malignancy, so sometimes I switch to the BD. Is that right?
Yes, I think so.
Okay. Thank you very much. Is there any comment? Yes, Sensei.
Okay. How often do you perform a rendezvous technique?
Yes, I studied earlier, and in the 2000 ERCP, we performed youth rendezvous with 16 cases.
16.
16.
It's 0.8%.
Yeah.
Okay, good.
It's very, it's not so often, yes, but sometimes needed. So we should know the various approaches and various devices.
Okay, thank you.
When you decide during the same session or next session you perform?
Yes, I don't perform the pre-cut technique usually. I prefer pre-cut. I prefer rendezvous than over pre-cut. So if I perform the pre-cut technique, another session ERCP is useful because pre-cut affects ERCP later easy. But I don't perform pre-cut, so basically I perform ES rendezvous in same session, in first session. If we obtain the patient accept before procedure.
Oh, you get informed consent before the ERCP procedure.
Basically, yes.
Okay. Oh, very good idea. Thank you very much. So, other comment or question? Nothing.
Okay.
Okay. Thank you very much, Sabrao.
Thank you.
Very good talk. So, thank you very much for attending this session. There are many attractive videos and also new information included. So the interventional ES developing day by day, and but the safety is very important. So many all speakers think about it. So but we should go advance this new technique. So there are many benefit from this new technique, and we should advance not only procedure, devices, but also indications. Okay, it is. Thank you very much for the many speakers and attendees. Thank you very much.
Thank you.
Thank you, Sandeep.
Thank you.
Thank you. Thank you, Professor Isayama, Ichiro, and all dear friends there.
Thank you.
Thank you very much, the moderators and all speakers.